Management of the dysfunctional uterine bleeding. If the patient present with the dysfunctional uterine bleeding and having any structural lesion which are not responding to the hormonal therapy, if the patient have the heavy menstrual bleeding due to the chronic endometritis, we may it must be treated with the course of the antibiotic. Or if the patient have the bleeding due to the hypothyroidism, which is also treated by the giving thyroxine, and PCO also treated medically. These all patients are treated and restore their regular ovulatory cycle through the medical management. How we will choose the management plan for the chronic heavy or the prolonged uterine bleeding in the premenopausal woman? We must know her etiology and severity of the bleeding by asking about her anemia, interference with the daily activities, associated symptoms, any contraceptive method she use, are planned for the future pregnancy or not, what are the contraindications, any medical comorbidities, and patient preference also important. Is patient is preferred for the medical or surgical treatment, or short or the long term therapy. So patient preference also important. Medical therapy is the initial management. The patient is not anemic and having not risk of the endometrial neoplasia, so we must go through the expected management, but we check her hematocrit level after 6 to 12 months in these patients. We must evaluate for the endometrial hyperplasia and endometrial cancer in the patient of the heavy menstrual bleeding. If the patient is postmenopausal, or her endometrial thickness is more than 4 millimeter, or if the patient have the heavy menstrual bleeding in which the interval between the onset of the bleeding and the episode is less than 21 days, or her loss of the volume is more than 80 ml. So we must exclude the endometrial hyperplasia or cancer. Or if the patient have the abnormal uterine bleeding is persist and taking the unopposed estrogen exposure, or taking the tamoxifen, or if the patient have the cervical cytology result the presence of the atypical glandular cells, then we must rule out the endometrial carcinoma. Other indication, if the patient have any endometrial pathology having the endometrial hyperplasia or Lynch syndrome, in all these conditions we must exclude the endometrial cancer. What are the risks for the endometrial cancer? If the age is more than 50 to 70-year-old, our patient is taking the unopposed estrogen therapy, taking HRT or tamoxifen therapy, early menarche, late menopause, nulliparity, are having the PCOS, obesity type 2, 3 and 4, type 2 diabetic mellitus, estrogen secreting tumor, Lynch syndrome, family history of the endometrial, ovarian, brain, or